Bismillahirrahmanirrahim. Dear all SESME members and participants, Assalamu alaikum. A very warm welcome to this webinar arranged by Saudi Society for Medical Education, Riyadh Office, General Club. I'm Dr. Shazia Iqbal, Chairperson and Head of Continued Professional Development Activities at Saudi Society for Medical Education. And I'm very much pleased and excited to see quite good number of participants joining us because we are going to run this webinar series after a little break, which was summer break. And I can see quite good enthusiasm of participants to register and join. Thank you so much for joining. You know that in medical education, we always thrive for innovation and focuses on outcomes. It encourages the context based on the framework of competencies, and medical educators are keen to adopt instructional designs that organize health professionals training into stages and provide guidance for teaching and learning at each stages. Competence by design is a model of competency-based method in medical education, and interestable professional activities are authentic tasks of discipline that provide a comprehensive image of competencies and eventually inform promotion decision. This webinar will offer an insight into competency by design, EPA, milestones, mapping, and assessment. And I'm very much honored and delighted to present our distinguished speaker, Dr. Andalib Irshad. Very warm welcome, Dr. Andalib, to SESME Webinar Office. Dr. Andalib Irshad is Director of Faculty Development, Kuwait Institution for Medical Specialization, Ministry of Health, Kuwait. He is an expert in competency-based medical education and National Faculty Lead with Royal College, Canada. Dr. Irshad has 20 plus years of experience as medical educationist in internationally renowned organizations, including National Guard Health Affairs, Saudi Arabia, and Aga Khan University, Pakistan. Training and development, curriculum design, competency by design, assessment, accreditation, and digital learning are his area of interest and expertise. So again, very warm welcome, Dr. Andalib. And this session will be recorded, and all participants who are registered for this webinar, we will provide them recording of this session. And I will be moderating this session. You can put your question in chat box by end of the session, and or raise your hand for any questions. We shall take questions by end of the session, and please keep your mics mute. And without any further ado, Dr. Andalib, over to you. Yes, we can see.
Okay, are my slides visible, right?
Yeah.
Okay, thank you very much. Thank you very much, Dr. Shazia, for this small introduction. And thank you very much for giving me the opportunity to talk on this topic, competence by design. I'm Dr. Andalib Irshad, as Dr. Shazia has already introduced. I'm Director of Faculty Development, Kuwait Institute for Medical Specializations. A very brief introduction. Kuwait Institute for Medical Specializations is just like the Saudi Medical Commission in Saudi Arabia, and just like the College of Physicians and Surgeons in Pakistan, or the other royal colleges in all over the world. So we deal with doctors who are doing residencies and fellowships. So we deal with their training and we deal with their examinations. So in this session today, we are going to define what are EPAs. As Dr. Shazia said, EPAs are interestable professional activities. So we're going to define them. We're going to define what are milestones, what is the importance of milestones and EPAs and competency by design. So we're going to spend some time on describing what is competency by design and what is workplace-based assessment, WBA. And then we're going to explain the rationale for competence by design. Why should we have competence by design? So here are some, I see that there are a few people who are joining with, and their mics are open. So please, if you could mute them. so that, yeah, the noise is not there. Thank you. So here are some real life training issues. For example, in an undergraduate medical school, we see that in a surgery exam, which is surgery is usually done at the end of final year, right? And we see that students fail in surgery exam. And then the reason which comes out is that they lack the core anatomical understanding. Now, my concern is that anatomy is something which perhaps they have done in the first 2 years. And then there had been so many subjects that perhaps had needed anatomy throughout, right? And then it is only at the end of the 5th year, we are failing them and we still are concerned with their anatomical understanding, right? So perhaps it is not the student who is failing, it is perhaps our program which is failing, which is not able to detect or which is not able to aid the student to develop all this understanding over the 5 or 7 years during the medical school. Then in a postgraduate training, there is specialized, for example, in internal medicine. Now, internal medicine postgraduate specialization in Kuwait is 5 years usually, and at some places in some royal colleges, it is 3 years also, right? So then we meet these residents that come to us in OSCEs, and then they would fail in OSCE only for a very, very simple reason that they were not able to perform a proper abdominal exam, right? Now, again, the same question comes up that why are we failing them only here at the end of 5 years of training, right? Then how safe were these residents over all those 5 years when they were perhaps at times independently looking at the patients, right? Independently examining them. And now at the end of 5th year, we feel that they are not able to perform even a simple abdominal exam. So why was this feedback not given to them over all these 5 years? Why was not there a stage when they were actually stopped and told that, see, this is something that you have to learn and improve on before you progress further? And then this is also something which we see very often is that we get to see that a resident or a student is ineligible to attend an exam, and then when it is asked from the administration to provide a reason why this person is ineligible to attend exam, that the only reason is that he has been missing clinical duties, the attendance was not that good. But if you dig inside, so this is also, for example, this is an example coming up from postgraduate programs. So in postgraduate training programs, right, at the end of final year, there is a fighter. That a fighter is final in training evaluation report. So they cannot sit the exit exam, the specialization, specialty exit exam if they do not have a successful fighter, right? Now, the problem is that attendance is something which we all record. Everything else related to their professionalism, related to their communication skills, perhaps has not been recorded. The problem might have been in their communication skills, in their attitude with their seniors, in their attitude with their colleagues, right? So in their professionalism, right? So the problem might have been there, but since those things were not being recorded and only attendance was recorded, so attendance is given as a reason, which might not be the very right reason, right? So we are failing to actually detect them properly, and then it's only the exams where we are providing a barrier and stopping them before, because we perhaps are feeling that they might not be safe if we graduate them. So some issues with current training, and even if it is undergraduate or postgraduate, the issues are kind of common, that learning is judged by the time spent and not ability, right? So there are perhaps not continuous assessments happening. So at the end of a rotation, since they have spent 2 months in a rotation, it is thought that as if they have learned everything that they had to learn during that rotation, which actually is not true. People learn differently, and perhaps you are not gauging them, right? So for example, if a rotation was in nephrology, have they learned all those things that they had to learn in nephrology during that rotation? We do not know. We don't know if their abilities have developed or not. Only because they have now finished their 2 months, we sit with them to do a feedback, or we progress them to the next rotation only because they have finished their time. So then there is a failure to fail, which is especially what we see in our postgraduate programs, that consultants and supervisors are very concerned. They're like, see, this is a colleague. He's not a specialist. He is into specialty training, but after 5 years, he is going to be a specialist beside me, right, in my own discipline. So therefore, out of culture, out of regional context, we don't want to fail them, right? Because we know that, 5 years down the line, 6 years down the line, he is going to be my colleague, right? So I don't want to stop and fail him right now. No one wants to take that responsibility, or you could say, take that blame, right? We might think that this is something which is cultural, which is in our region, but it is not limited to here only. We hear the same things from Canada. We hear the same things from North America and Europe. Faculty usually does not take the responsibility of failing a candidate only on themselves. So there is a failure to fail. And then one of the big reasons for failure to fail is dichotomous judgments, right? Either they could fail them or they could pass them. There is nothing in between, right? Therefore, there is nothing like, okay, you are weak. If you improve on it, you go ahead, right? So at the end of a rotation or at an assessment, they either could fail them and stop them there and ask them to repeat the whole thing, or they just pass them. If they are weak on certain things, they even then, they let them go ahead. And with this thing in mind, as if when they go to the next rotation, they're going to develop themselves there, which is not checked, they might not do, and they might not work on the weakness in the next rotations, because perhaps it was not detected properly, and then they, as a learner, also do not know what their lackings are. Okay, and then of course there is little direct observation. People who are taking exams are way different than people who are actually there in the clinical context, looking at their performances and working with them. So residents and students are always like, see, I have been attending, I've been doing the hard work, but when it came at the day of the exam, the person was very different, right? And this person never knew what I have been doing over the 6 months, right? So he never directly observed me. So perhaps he is not the right person to make judgments on me. So there is little direct observation. And when you don't have all these things, so then the only barrier, the only firewall that you are left with is exams. And therefore the exams become high stakes, right? So when programs are weak, when we as faculty do not believe on our own training programs, right, that we were able to detect people properly, then what do? We don't want these weak graduates to actually graduate and start independently practice. So what do? The only thing we are left with is to make the exams difficult, right? Which is perhaps not the right way of doing it. We make the exams difficult, and that is the only barrier for us to stop the weak candidates. And let me tell you, we can't be, still then we can never be sure, because these weak candidates who have not been attending over the years, but then they might be very good exam takers, right? So they might still proceed and might still graduate. So this is something which Royal College Canada has developed, right? So instead of, they would say that let us take competence, let us take competence as and let us say that when somebody joins a postgraduate training program, right, we don't want him to be competent in the very beginning, right? So for example, if somebody joins pediatrics, they would say this person has been taught in a medical school to be a general physician, right? So let us now introduce him to pediatrics, him or her to pediatrics first. So that is the very first level that they would say the very, very first stage is transition to discipline. So instead of calling it as years, instead of calling it as resident level 1, R1, year 2, year 3, year 4, they are actually giving it names, right? So the first stage, they would say this is transition to discipline. The second stage, they would say, is foundations of discipline. The third is core of discipline. And then they take an exam. The Royal College takes an exam in the middle at the end of the 4th year, right? Where the core of discipline is finishing for the specialty training. And then the last year is transition to practice. And then when they finish the final year, they are certified to be specialists, right? Okay, so this is something for postgraduate education training. In our case, in undergraduate, we could also, we have this thing called year 1, year 2, year 3, year 4, right? Here, but the difference is that we have got these disciplines. We have to deal with them in pediatrics. We have to teach them internal medicine. We have to teach them general surgery. While in a postgraduate specialty training, they are just doing pediatrics only, right? So therefore, we could divide them into these stages, right? In case of undergraduate programs, the competence spectrum would be a little different, right? And so that has to be, a team has to work on it, right? But let us go ahead and see what it would be like. Now, before going into the details of EPAs and competence by design and the spectrum, let me first start by defining what is competence by design. So competence by design is an outcomes-based approach using an organizing framework of competencies, CANMETs, EPAs, and milestones. And competencies are based on the abilities needed to practice, right? So when we take a resident, right, we instead of saying that, okay, he is a resident in pediatrics or he's a resident in urology, right? And urology as a discipline has these 25 topics, right? As a discipline, or a general surgery book has all these chapters. Instead of, and we have to cover them, instead of thinking in those lines, we start thinking on an outcomes-based approach. And the outcomes-based approach is that when this person becomes a specialist, what would he or she be required to do independently, right? So when a general surgeon becomes a specialist, he might be required to do a laparotomy independently, right? So laparotomy is an activity which he might be required to do independently. He might be required to do an appendicectomy independently, right? So all these things become our EPAs, right? And we'll come to EPAs again, right? So these. Now, once you identify, so for example, the Royal College, how did they develop it? They did it this way, that they took from every university in Canada specialists in disciplines, right? And these specialists sat together and they identified the EPAs for their discipline, right? So they came up with, for general surgery, for example, 18 things which a general surgeon as a specialist has to do independently. They came up with, for microbiology, for example, uh, 12 things that a microbiologist has to do independently when he becomes a specialist. Similarly, for an undergraduate school, that is a point. We have learning objectives written. So they had learning objectives kind of written in the form of CANMEDs, right? In EPAs, they actually mapped those learning objectives. They took things out from the organizing framework, which was CANMEDs, which had all the competencies there. They took those competencies out and mapped them into activities, the activities that will be required in the end when they have to practice independently, right? So they kind of took those competencies out and mapped them. And then, of course, these competencies keep on overlapping a lot. Similar is the case in undergraduate medical programs also. We have to think of the fact that though we are teaching them gynecology, we are teaching them, for example, pathology, we are teaching them, for example, general surgery, we are teaching them internal medicine, but what do we want in the end? We want the general physicians. We don't want pathologists to be coming out of our medical schools. We don't want pediatricians to be coming out of our medical schools. That is beyond of our scope and capacity, right? We want general physicians to be graduating, which will later on go into different specialities, right? So we got our competencies. So then our competencies cannot be that complex enough, that complex, which specialty training competencies are, right? So our competencies should be at the level of a general physician. And then these competencies have to be mapped into activities which a general physician does. So a general physician, for example, should be able to, when he sees a diabetic patient, right, provide a general provide that patient with the medical care that is needed, and when there are complications, he knows his limit, when to refer that patient to a specialist. And similarly, when he sees a child, things that he could manage himself, and when he has to refer, right? So all these things, right? So therefore, we then these will become the activities of a general physician, which we should. But the point is that learning objectives, we all have it, right? So just like CanMeds we had in postgraduate programs, almost all medical schools have learning objectives, but it should be at a national level, right? At least a national level, that we sit together, different medical schools, right? In, for example, Saudi Arabia, or different medical schools in Pakistan, or different medical schools in India. We sit together, right? We sit together and we identify that, okay, these are the learning objectives, but what are the activities that a general physician does, right? We identify, say, for example, 26 activities that a general physician has to do independently, right? So we take experts from all these medical schools, we identify that, right? And then we map the learning objectives to those activities. We kind of populate those activities with our learning objectives, right? So the point is that this should not be done, and not a single school has a capacity to do it. It should be at a national level. It should be done by a national body, right? Just like Royal College is a national body for postgraduate education, right? Okay, now Going now more into what are EPAs. EPAs, as the word goes, are interestable professional activities, right? By definition, an EPA is a stage-specific key task that an individual can be trusted to perform without direct supervision in a given healthcare context, right? So an EPA is a stage-specific key task, right? While milestones are observable marker of a person's ability along their developmental continuum. So the different milestones combine together and they form an EPA. Right? If I give you an example, it will be much more easier. For example, managing cardiac arrest is a specialty specific EPA. And what does that mean? For example, managing cardiac arrest can be an EPA for adult cardiology program. Managing cardiac arrest can be an EPA, an entrustable professional activity for internal medicine. Managing cardiac arrest can be an EPA for emergency medicine. Managing cardiac arrest can be an EPA for a general physician coming out from an undergraduate medical program also. But then the complexities will be different, right? For an adult cardiology, it will be way more complex as compared to for a general physician coming out from an undergraduate medical school, right? So the EPA might be same, but then the competency that you will be requiring will be way more higher, right? Now, different milestones, they combine together and form an EPA. For example, managing cardiac arrest, the EPAs are, some of the EPAs are mentioned here. For example, cardiac rhythm interpretation, the ability to interpret an ECG, right? Now that is an EPA which can be used in managing cardiac arrest, but then if there is an EPA of managing cardiac failure, right? Or if there is an EPA of managing cardiac ischemia, right? All those EPAs also require cardiac rhythm interpretation as a milestone. So the milestones are kind of letters, right? They're kind of alphabets. And then the EPAs are kind of words coming out of these alphabets. So these alphabets or these units, these milestones will be combining in different ways, right? And becoming EPAs. Now, let me take it back to what we have in medical schools. We have in medical schools outcome-based learning objectives, right? These outcome-based learning objectives are actually the milestones, right? They have to be mapped into EPAs. That thing is kind of a little missing, right? We have all those objectives written, we just map it to the rotations, or we just map it to our modules, and that is it. And we feel that it covers all. It won't. When they go to a rotation, when they go through a module, they actually go through problems, they actually go through cases, right? And they solve those problems or they manage those cases, right? And they're actually doing the EPAs, right? So if we map it to them and you tell them that these will be the EPAs, life will be much more easier for them, right? And they will always keep on seeing that, okay, this milestone of, for example, doing a proper CPR, right? It is coming back to us in so many different EPAs. Okay, now here is one example of an EPA, right? And so this is EPA number 1 of the Surgical Foundations Program, postgraduate training program. It comes from the Royal College. The Royal College has written this EPA, right? So for example, in the Surgical Foundations, they have a total surgical foundations. They have a total of 13 or 14 EPAs only, right? It's a 2-year program with 14 EPAs only, and that is all that residents have to cover in those 2 years. Now, which stage is this? This is, I can't see it. Okay, let us see, let us say, what is the title of this CPA? The title of this CPA is Assessing and Providing Initial Management Plans for Patients Presenting with a Simple General Surgery Problem, right? Because this is something that they will be required to do at some point of time when they become a specialist. The key features, so this CPA starts with telling us what the key features are. Now, the very good thing about when they developed EPAs is that before they go into the details and the milestones, they first give you how to actually assess this EPA, right? So first they will give you the assessment plan for each EPA, and then they would go into the milestones which are related to this EPA. So they would say, in this very EPA, it needs a direct and indirect observation by a surgeon, a surgical fellow, or a core or transition to practice resident. So we saw that they have, in the postgraduate specialization, they have these levels, which were transition to discipline, then foundation, then core. So this EPA can have a direct observation and can have an indirect observation also, right? By a surgeon or a surgical fellow in that rotation, so somebody who is doing a subspecialization, or by a senior resident also, who is at the level of core or transition to practice. Transition to practice is the topmost stage, and then they become specialists, right? Now, there are 4 different types of forms, template forms, which are to be used to assess it. Here they would tell you that use form 1, right? And the form 1, they would tell that it collects information on the setting, that where are you observing them, right? So where are you assessing them? You can assess them in inpatient, in outpatient, or in an emergency situation. And what kind of an observation could you do? You can do a direct observation, but you can even do an indirect observation also, right? Then it would tell you how many observations of achievement is needed. And then it tells you that 5 observations of achievement are needed. So if somebody has done 5 observations and those 5 observations are achieved, right? So there is a scale which tells you that, okay, this score is kind of that they have achieved this CPA, then they have covered the CPA, right? So they can do these observations with all these faculty or with all these assessors that have been highlighted earlier multiple times, right? So if it is a weak or a slow learner, he might do these observations 10 times or 15 times. And then out of these 15 times, he might get kind of like 5, which he has achieved, right? So it's kind of a game for the residents, right? If they feel that they are good in the CPA, they can go to the observer, but then the observer tells, no, you're not achieving it, come back to me after some time, right? So then they can go perhaps after a day or 2. And then when they get these 5 observations of achievement, then they have achieved the APA. At least 1 direct observation, at least 2 different observations. So it's even telling you that these 5 achievements cannot be coming out from only one observer, right? It has to come from at least 2 different observers, right? And at least 3 observations by faculty. So these 5 assessments or these 5 observations of achievement cannot be coming all from the senior residents. 3 has to come from faculty, 2 can be from the senior residents, right? So all details are given. And then the milestones. Now, for this general surgery EPA, which was about what? Which was about assessing and providing initial management plans for patients presenting simple general surgery problem, right? So how to assess and provide initial management plan. Look at the milestones. So the first milestone, as you can see, is P1.2, right? And if you know CanMeds, right, then P in CanMeds is professionalism, right? So here Now, all those things from CanMeds, all the competencies from CanMeds are uh, mapped here as milestones for this EPA. So the first EPA, so the first milestone is coming out from the professionalism domain of CanMeds, right? The 1.2 of professionalism, which is prepare for the procedure reviewing relevant investigations and operative assessment consults. The second the second milestone is the medical expert competency, right? The third milestone is again from the medical expert domain of CanMeds, but this time it is the 5.2 for medical expert, which is participate in surgical safety checklist or equivalent, right? Now here, for example, look at the 9th EPA. It is COL. So that is a collaborator domain, right? So collaborator domain competency 1.2 is a part of this EPA as a milestone, right? P is again professionalism. Then, of course, in order for someone to do this thing independently, you need their communication skills also. So number 12 is communication, right? It is 5.1, document the surgical procedure in a complete and timely manner, right? So EPAs are kind of, I usually define EPAs as EPAs are just like, the activities that they should be able to perform, and EPAs are have all those abilities mapped up. So the abilities are milestones. So let us be clear that EPAs are the tasks or activities that must be accomplished, whereas milestones are the abilities of the individual. So there are certain abilities, right, which were lumped together into an EPA. These abilities make a person capable of achieving the task. So the competency by design process goes something like this, that in the very beginning, they get all the EPAs and milestones, right? So for example, if they are in a general surgery program, or if they are in a nephrology program, from the very beginning, they will get their EPAs. In nephrology, for example, there are 18 EPAs. So they will, in the very beginning, know that they only have to, over 5 years, they only have to get achievements, the required achievements in these 18 EPAs, and that is it. And even they know that of these 18 EPAs, 2 are going to be in the first stage, 3 are going to be in the second stage, right? 6 are going to be in the core stage, so they even know that, right? So everything is very clearly laid out to them. And what happens is that they do the normal work. So they do the normal, for example, if it is in our undergraduate, then they will be doing the normal classes, right? But they will be assessed on the EPAs. And in our specialty training, they keep on doing the normal ward activities. Whatever is happening in the ward as they were doing earlier, they're gonna do it now also, right? So whatever is happening in the wards, whatever is happening in the outpatient clinics, whatever is happening in the surgical theaters, they will continue doing it. But then the focus is on getting that assessed also, right? So they will be doing lots of workplace-based assessment. And the EPAs, every EPA comes with its own specific kind of, its own customized assessment, as we saw. Some EPAs will require only 3 achievements, right? Observed achievements. Some EPAs, which are more intense, have to be more thorough. They would require 20 achievements, right? And all these achievements get logged in the format of e-portfolio, right? So they don't have to think of the forms. They just in that e-portfolio. We are going to use Elantra, for example. 145 also does it, right? So when they just log in, the e-portfolio knows which stage they are. It tells them that these EPAs they have to cover, and then the faculty also knows that, okay, this resident, these EPAs, and then they just assess them there. Now, faculty is assessing them on site, But then all of these assessments, they come to a competence committee, and then the competence committee decides that, okay, the EPAs have been achieved, and then they can move to the next move to the next stage or not, right? If they can't, if they feel that, there is a certain EPA that has to be still done, then they would tell the resident or the student that, okay, you finish this EPA, you can move to the next stage. Now here the question is, which usually people ask, is that fine, if, for example, the first stage is 6 months and only 2 EPAs, right? And if the student is very smart, or the resident is very smart, right? And he finishes his 2 EPAs within 2 months, right? Then what does this person do, right? So he has done all the achievements that have been required within 2 months, and then he has got kind of 4 months remaining. Theoretically, educationally, ideally, he should be now moved to the next stage, because he has developed his ability. He has shown that he can do those things independently that are required at that very stage. But in real life, we are not moving them. The Royal College is not moving them. We at Kuwait also are not going to move them, right? So then, even if they have achieved it, of course, since the stage is 6 months, they keep on doing the normal activities for that stage, all the rotations, whatever is required, as they were doing earlier, right? So they keep on doing it. They might have just finished their assessments, but the work is still there. So they have to spend the time also. Now, Dr. Shazia, can you check if there are any questions now? I don't see in chat there only.
Yeah, I just checked. So far there are no questions,
yeah.
so you can
Okay.
complete and then we can take questions.
Yes, yeah. But if there is a question, right, you can always write it. So okay, now let's look at the observation templates, right? Now, this is very interesting. This is where the difference actually lies, right? We have been doing OSCEs, we have been doing mini CEX, right? So what is the difference in competency by design? What is the difference in, how is it different from the mini CEX that we have been doing, right? And the workplace-based assessments that we've already been doing. The difference here is that the scale to assess them is different. Instead of assessing them as from poor, in a spectrum of poor to excellent, right? Poor, satisfactory, excellent. We assess them on trust. How much would we trust them to work independently? So the scale for assessing them becomes a little different for the EPAs, right? Now, there are 4 template forms. Most of the time in competency by design, we use form 1 and form 2. So you see in the EPAs that each EPA will be telling that this EPA will use form 1, this EPA is going to use form 2, right? Each EPA is telling that. Form 3 and form 4 are not used that much. Form 3 is kind of multiple source feedback. So, and form 4 is just a narrative observation. If there is something which is very particular, very specific to a resident or a student, which perhaps, you feel that won't be covered in EPAs, then you give them a narrative observation to that very person, form 4. It's kind of a very open form for general comments, right? For open comments specific to that very resident. So form 1 and form 2. Form 1 is kind of like for cognitive assessment. So things related to cognition, EPAs related to cognition, and a mix of cognition and psychomotor. They use the form 1. And form 2 is more about procedural competencies. So anything which is psychomotor gets assessed in form 2. I have an example of form 2. So this is an EPA, which is perform a lumbar puncture. This could be an EPA for example, EPA for the the foundations stage of neurosurgery, right? It doesn't mention because this is just an example. So all those details are not there on the top, right? So this could be an EPA for the foundation stage of neurosurgery program, right? It says that the resident should be, or the should be able to perform a lumbar puncture, of course, independently, and therefore it is an EPA, right? Now, as I said, look at this line after, sorry, I told you, yeah, I said foundations, right? So the EPA stage, it mentions here that it is foundations of discipline, right? The only thing which is not mentioned in this template is which program it is. But let's say it is the neurosurgery program, right? Now, after complexity, look at this. This is the scale that I was talking about. Based on this observation overall, so you kind of give them an overall based on you saw this person, this resident, right, or this student performing a lumbar puncture. And performing a lumbar puncture, I would say, could be an EPA for our undergraduate medical programs also, right? It depends. It depends if, specialists and faculty members who decide, and they decide that, okay, a general physician should be able to perform a lumbar puncture independently when they graduate, right? And then when they start practicing as a general physician. If they decide that a lumbar puncture is something that they should be able to do, then they can keep it as an EPA for their medical college program also, medical school program also. Okay, but let's come to here. This is assessment based on this observation overall, right? And that's the trust scale. I had to do it myself. So based on this observation that I have seen and I've done with this resident or with this doctor, actually I had to do the lumbar puncture myself, right? So that is the lowest level of trust on that very resident or that very student, right? You had to do the procedure yourself, or you had to talk them through, right? So you were telling them the steps and he did it. That is a little higher level of trust. Or I needed to prompt. So the resident or the medical student was actually doing the procedure, but still there were times that you actually had to prompt them. Or I needed to be there just in case, right? That is a high level of trust. You were just there, but he was doing it all by himself, right? Or your trust is such higher that though you were there, you directly were observing it, right? Or, but then your trust is such high that I trust him to such a level that I didn't need to be there. Even if I was not in the room, based on what I've seen him doing, I can easily say that this person can do it even if I was not there, right? So this is a scale based on trust. Now then, as the form goes, each of the milestone could also be using the same trust score to assess, right? But then the one on the top, the general observation is more important, right? So the GRS, the global rating score on the top is actually more important when it comes to EPS. So overall effect, the overall perception that you're getting out of that very observation is more important, right? But then we do the milestones also just so that we could tell this resident that I feel that right now you are at, I needed to prompt, and these were the milestones that actually I was prompting you on, right? That needed, that are perhaps your weakness at this very level, and you have to move to, if you want to move to the next level, which is a requirement for this very stage, right? So for example, for a final year resident whom you are going to graduate, and if the lumbar puncture comes again, right? So if lumbar puncture comes again as an EPA, then perhaps you will require him to be at which level? At this level. I didn't need to be there, right? Because he's within 2 months, he will be actually doing it independently, right? So he has to be here, or this EPA won't be considered achieved, right? So this is something which for every EPA, the competence committee decides. So you set up a competence committee, right? And they decide for every EPA, what is the level of trust that is needed, right? Okay. Now, so as we said, the competence committee decides on many things. So competence committee will review the residence progress. That is actually their main job. They review the residence progress. So if that stage had 4 EPAs, they would see if all those 4 EPAs are achieved. So they will review every resident in details, and then they determine if the resident is ready to be promoted to the next stage of the competence continuum, right? And let me show you the competence continuum very quickly again, right? So in the postgraduate programs, the competence continuum for us is something like this. So it is here, for example, the competence committee would meet here, right, at this stage and decide that the resident is going to move from transition to discipline. Can he or she move to the foundations, or at the end of foundations, they would meet again, and then they would decide if the resident can move to the core of discipline or not, right? Based on if they have covered all the EPAs that were required earlier. Okay. Now, if I can pose this question.
Looking into time, like try to make conclusion and summarize, because we are running short of time now.
Okay. Then I'll leave this question, right? And this is kind of the second last slide. So learners are actually winning in competency by design. They have a very clear learning path, right? So from the very beginning, they know that, okay, they have to cover 12 EPAs, they have to cover 15 EPAs, whatever the number is for their discipline, right? And this path is in the form of EPAs and milestones, right? They have very self-directed, flexible learning. So for example, if there are 3 EPAs in a stage, somebody can go for EPA number 3, and that is fine, because he feels more comfortable with EPA number 3. He can go and do the assessments for EPA number 3 first, right? So EPA number 1 is not EPA number 2 or 3 is not dependent on EPA number 1, right? So every stage they have this flexibility. And then there is always frequent meaningful feedback happening all the time, right? So, and then the competence committee makes promotion decision. It is not one person who is deciding for them. It is not one examiner at the day of the exam deciding for this very person, right? If it is, for example, let's go back to that example of doing a proper abdominal exam. So proper abdominal exam as an EPA might need 20 observations. So it is actually 20 times or perhaps 25 times, right? Pupil will be observing and deciding for this very person if he's doing it properly or not. It's not only one OSCE that is deciding his fate or her fate. So what we did today is we defined EPAs and milestones. We described what is competency by design. It's kind of mapping all those milestones in the form of EPA. We saw workplace-based assessment. We saw the forms. We saw that the EPAs, even from the very beginning, they talked about their assessment before moving into the milestones, right? So there's a huge component of workplace-based assessment in competency by design. And of course, the rationale to competency by design, why we need competency by design, right? I think I've done it.
Yeah.
So if there are any questions.
Thank you so much, Dr. Andalib, for this wonderful presentation. It really gave us insight that how interestable professional activities are being incorporated in courses as well as in different aspects of assessments, especially the way you have elaborated all assessment forms. Thank you so much. I can see that there are a few questions in chat box. And meanwhile, participants, if you have any question, you can raise your hand. I will take this hand, Alira Healy, a bit later. There are 2 questions. So first question is by Dr. Azim. Thanks for nice presentation. In those items are sub-competencies related to specific EPA rather than milestones. I don't know on which slide was this question, but let's see. Let's try to understand the question. Is there any difference between meaning of milestones in ACGME model of OBE and Royal College model of OBE? As I know that in ACGME model, milestones are more stages of development of a single competency rather than part of it. So if you got question, yes, please, you can answer. Otherwise, Dr. Azim, you can unmute and can ask.
Yeah,
Yes, Dr.
no, still, but if he wants to, elaborate his question more, that is, yeah, we can do that. But otherwise, yeah, I got the question.
Yes,
right?
Dr. Azim, please, you can unmute and can discuss.
I hope. Thank you so much. I'm Azim from Mizazadeh from the University of Medical Sciences. Thank you so much for excellent presentation and elaboration on such a complex model. It's a really tough task for every person to organize a presentation around this topic in a short time. But my question is about when we talk about milestones, as I know, milestones, as you mentioned, is different stages of development along a continuum. But as you mentioned, for example, for EPA, you exemplified by, for example, blocks that develop a building. And this is in contrast with my understanding of milestones. Milestones is stages development in a single competency or sub-competency, not different parts that put together and finally develop EPA. Those are sub-competencies or competencies that put together to define an EPAs. And therefore, I was somewhat confused about the difference of sub-competencies and milestones.
I agree with you. Right. This is why I tell the Royal College Canada that this term milestone for the competencies is actually a misnomer, and you have actually picked it there, right? It's if it's actually competencies coming out of CanMeds, right, and being combined together in different forms in EPAs, right? So, and then they would say that these are milestones only for this very EPA, right? Though it's a misnomer, right? So yeah. So I agree with you. Yeah. You are right,
Thank you.
and you are very right that other organizing frameworks are using the term milestones differently, right? For them, for Royal College Canada, they would say this is a milestone for only this very EPA, right? So in this very EPA, but of course, as you very really rightly said, it's actually not in a continuum, right? So shouldn't be called milestone.
Thank you so much. Thank you so much.
Thank you so much. Dr. Andalib, another question and rather request is that is possible, please share form 1, 2, 3, 4 and their links, and also link to the list of objectives and EPAs from CanMed. Yeah.
Yeah.
So
this is open source. This is open source, which the Royal College has provided it, right? If you go to the Royal College Canada site, you can get lots of things related to CBD there. But what I will do is I will give Dr. Shazia this link, right? Actually, it's a PDF form with all these. So I shared only here out of time, only form 2. So it will have form 1, form 2, form 3, form 4, empty forms, and then their examples also. And she can email to all those that all of us here.
There's a question by Dr. Mona Abdul Saud that suppose the residency program is 5 years long and resident needed more time to achieve different EPAs. Does the resident spend more time than 5 years?
Yeah, that's usual. That's usual, right? The point is that we always have it, right? So for example, we as a policy has this, that it's a 5 years training program, but you have to finish it in 8 years, right? Right? It's just like, when somebody is doing a PhD, we always tell that it's it's a 3 years program. A PhD is a 3 years, but you can finish it in 7 years, right? So yes, they can. But since now they will know, it's not about them repeating a full year, right? They know that it's only these 2 EPAs, and then they can finish. But if the exam is happening at so they might just have to wait for the exam. If the exam is happening only twice a year, then they might have to just wait for the exam. But once the EPAs are finished, they are finished. They don't have to repeat the whole year or a full 6 months rotation.
All right, thank you. Yes, Dr. Ali Rahili, you can unmute and can ask your question.
Thank you very much. It's a very informative talk, Dr. Andalib. You made APA quite easy to grasp. I have a questions regarding the work-based assessment tools. When you're doing the mapping with the APAs and assessment tools, I thought we can utilize the mini CX, the case-based discussions, the DOPes. Where can we put that in the EPA before the final procedural competency template 2 or 1 or 3 or 4? So just yes. Can elaborate more on this part. And thank you very much for the beautiful
So
talk.
if you look at this EPA form 2 that is open right now, right? And it's kind of very close to a mini CEX, right? It's kind of very close to the mini CEX, right? Except the fact that the scale is based on trust, right? And I think it is much more useful to use this scale. It makes more sense, because even if we are, in the other scale, the Likert scale of excellent and poor to excellent, even if we are, telling that this resident is excellent, it is actually, we are telling that we trust this resident to work independently, right? So kind of this replicates the mini CX, but what happens in mini CX? In mini CX, every time we as a faculty, we develop those items, which has to be, assessed in a mini CX. In another medical school, somebody would develop a mini CX a little differently, right? So here in EPAs, things have been standardized. If this is the EPA, then these are the milestones, or these are the competencies, the sub-competencies that you have to check. And so this is kind of a standardized mini CX. I would always call the Form 2 as a standardized, because Form 2 checks procedural and it's work-based, what mini CX also does. So it's kind of a very standardized mini CX. But still, if on your very discipline, you feel that you want to still keep the mini CX, fine. You can still keep the mini CX, the score can go and submit somewhere, right? But the point with competency by design is that in order for all programs to be standardized, you keep doing the EPAs. So the mini CX, if you want to keep them, that will be an extra.
All right. Thank you so much. Yes, Dr. Bahar, you can unmute and can ask your question.
Thank you so much, Dr. Andalib, for this nice presentation. My question is, we usually say in our undergraduate programs that we have a learning outcome of the program, a teaching strategy and assessment method. For example, when we say we have cognitive learning outcome, like understanding something, we have teaching strategy like interactive lecture and assessment method like written exam. Now the EPA, is it a learning outcome, a teaching strategy, or an assessment method? And what is its place within our undergraduate medical programs? Because we have tight national framework. I am talking about Saudi Arabian undergraduate programs. What is its place in the program learning outcome, teaching strategy, assessment method triangle? Thank you.
Yeah. Good, good. Can you tell Dr. Mohammed Bahar what is your institution? Because, you know, as people are speaking, Dr. Shazia, it will really help if they also tell which institution they are. Dr. Mohammed Bahar.
VN
I am
College of Medicine.
I am Director of Development and
Okay.
Center in the College of Medicine in Riyadh.
In Riyadh. Okay, very good. Yes, yes. So, see, that is the thing. We have, for example, in our medical schools, we have all the learning objectives written, right? Right. And then, of course, we know the teaching tools. So we know that, okay, lecture is a teaching tool. And then, you know, there are the teaching tools. For example, there are small group sessions, there are problem-based, there are problems which are teaching tools, right? So we know the teaching tools, right? Now, every medical school is kind of mapping them. They do some curriculum mapping. Some medical schools are very good in curriculum mapping, right? So when it comes to assessment also, their assessment is kind of also very well curriculum mapped, right? But then there will be some schools that are not that good in curriculum mapping. What happens in those schools? Residents get all these 250 learning objectives from the very beginning. They don't know what is going to be covered where, right? Or they just know that, okay, 100 is going to be covered in the first year, 50 are going to be covered in the second year, and that is it. Their exams are also not curriculum mapped. And then because since the exams are not curriculum mapped, we never get to know in such schools that, you know, if knowingly or unknowingly we were asking something with a higher weightage, right? We put this year, we put more questions on diabetes mellitus. The next year, we could put lesser questions on diabetes mellitus, right? Now here in competency by design, by identifying these EPAs, these activities that has to be done, we already have kind of mapped it for them. So now the Royal College is telling everyone who is using these competency by design for postgraduate programs that you don't have to do the mapping anymore. The only mapping you have to do is that you pick those rotations where these EPAs can be covered. And that is it. Don't have to take all the learning objectives and map them for strategies. You don't have to map them for different disciplines. You don't have to map them for assessments, right? Everything is already done one time and has to be used. So kind of a standardization. I don't know if there is, I made it clear, Dr. Bahar, did I miss something?
No, it's clear. Thank you.
Yeah, okay, thank you.
Thank you so much. There is one question by Dr. Anil Kapoor. Thanks for sharing concepts of EPA milestones with clarify, looking at the frequency of observations required for EPA. This looks difficult to be implemented for MBBS undergrad program. What is your experience of implementing competency-based curriculum for undergrad? Probably this was the same question which was I was about to ask.
Yes, so in undergraduate programs, we have competencies available, right? Many medical schools have actually written learning objectives outcome-based to such a good level that they are actually competencies, right? And many have already framed it also. For example, many in medical schools are using the CANMEDS framework, right? So the organizing framework is already there. And Saudi, I know that you people have Saudi MEX, right? So the organizing framework is only there, right? The only thing which is missing is that we should have the courage to identify these EPAs, right? So specialists from faculty, high-level faculty, experienced faculty from different medical schools should sit together under the umbrella of, I don't know, what should be the right body in your case, right? They have to sit together and identify and have to identify things that has to be covered, because we need to know that we are graduating people as general physicians, not as pediatricians. So pediatrics doesn't have to be in that detail, not as general surgeons, doesn't have to, let me tell you an example. I believe that the amount of pathology that we teach our medical students, right? Or the amount of pharmacology that we teach our medical students is way more than what pharmacy program teach pharmacology in universities, or pathology, a master's in pathology learns in a master's in pathology program. Our medical students learn way more, and then they actually are not using it as a general physician at times, right? So we have to just, we have to actually delete a lot. All the competencies are there, but we have to actually delete a lot of things, right? So only subject specialists can, do these deletions, map them as EPS and do it. Not one school cannot do it. That is my point.
Yeah. And in continuation of the same question, if we want to take STAR to introduce EPA at undergrad level program, so what will be the initial process? Should medical schools take initiative at their institutional levels, or there should be some guidance from Saudi Med?
Yes. So again, yeah. So at a national level, at institutional level, perhaps we do not have the capacity. We don't have the capacity. Any institution every institution lacks it. So it should be at the national level. How much time did the Royal College take to develop these EPS? Almost 7 years. Almost 7 years. So every discipline sat for almost 7 years. They worked for 7 years, and then they were able to delete all the extra thing and come up with, for their disciplines, only 20, 23 things, right? Which they are confident on that if these 23 things, right? So for example, the whole neurosurgery is only 18 EPAs, which means just every EPA is only 2-pager. Or 1.5 pager, right? So 18 divided by 2, it's like multiplied by 2 is 36. Just a 36-page PDF document, and that's a whole 5-year general neurosurgery program containing all the milestones for the EPS, containing all the details on what assessment has to be done, right? So, yeah. So yeah, the very first thing that a national body which has the mandate to do it should start doing it. Institutions sit together, work on it, right? It will take at least 5 years.
Yeah. There is one question by Dr. Mona. Can you use EPS for medical interns as well?
Yeah. See, most of our EPS, right, they have a transition to discipline. So most of our disciplines have transitioned to discipline, right? And the transition to discipline is like, you take someone who is a fresh graduate, right? And now he's entering a specialty training. So they're kind of very basic, right? Orienting them to the specialty. These transition of discipline, if you look at them, they are kind of like for interns, right? They suit to interns very much, right? So yes, we were not using it, but they can be identified very easily. They're actually there.
We can. Yeah. And so I think almost all questions has been addressed, and there are a lot of thanks for your wonderful presentation. And this is time to say wind up now. Thank you so much for this insightful presentation and for your precious time. And thanks to all participants to join us. And hopefully we have your emails, and I will share recording and the forms which Dr. Andalib will share with me. I will forward you. So by this, I would say, have good night.
Yeah, so thank you.
Thank you so much.
From Saudi Arabia, from Kuwait, from India, from Pakistan, from Egypt,
from different regions,
from Sudan.
Yes.
Yeah. Okay.
Thanks to all colleagues. Bye-bye. Good night.